Good morning, everybody. My name is Cyril Meyerowitz. I'm at the University of Rochester, Eastman, and it's a great pleasure for me to welcome everybody to the fourth Eastman International Association Global Rounds. We're very proud to have people from four institutions, from four Eastmans across the globe. This year, this session, we're particularly pleased to welcome Rome, the Eastman in Rome, for the very first time. We also have the Eastman from London, and we have the Eastman from Stockholm, and of course, the Eastman from Rochester, where I am. The session is a session that is going to run for an hour and a half. We hope you'll be able to ask some questions. If you ask the questions through the Q&A, I'll be looking at this piece so that I can actually direct the questions to the speakers. I also want to make a special mention this time to welcome Meharry University, because I think there's some people from there, and there is a linkage between Eastman and Meharry, and also the Howard University people. So welcome everybody, and let's get started with the session. Our first speaker, and from our new participant, Rome, is an excellent man that I've known for a long time, Luca Cordara. And Luca from Eastman Rome is going to speak on the implant disaster, some options when things go wrong. So it's all yours, Luca. Luca, Luca, your mute is on.
Okay, so thank you. I hope I am fine now. I will start my presentation. And let me thank the organization for inviting us. The Eastman in Rome has been founded in 1933. So it's a long story. We have recently merged with the University Polyclinic that is close by. So now the Eastman, together with the dental clinic of the University Sapienza, are the biggest dental public institution in Italy. I have been heading the Department of Perio and Pros since 2002, so it's a long time. And this is a picture of our institution. As you see, I would say a typical Eastman architecture of the 30s of last century. And, my topic today would be talking about implant disaster in terms of treatment planning. And of course, I would like to disclose that our center has performed different studies funded by companies and by international foundations. So it's good for you to know that we are collaborating with several institutions and several companies. Now, to go into the topic, we all know that the implant do show a very high survival and success rate in the long term, that we have a high survival rate of restoration, and that, of course, we also have good outcomes with reduced treatment time, and that we have excellent and predictable outcomes in terms of tissue regeneration. Of course, if you look at these data, it looks like implant dentistry is sort of something that works every time. Instead, we all know that we still see late failures. And sometimes these late failures are really disasters. And we have to keep our eyes and our head open, because we have several treatment options, and it is good to consider every single step that we have to go through very cautiously. So we will be talking today about failing or hopeless implants. Actually, I will show you 3 cases just to let you understand what our approach is. And the main part of my presentation would talk about when and why to remove an implant. It is very important to understand when it is the time in terms of the old prosthetic maintenance, but also in terms of management of the provisional restoration. And after we have removed the implants, how can we restore the patient again? Because of course, we are all focused on the implants, but at the end, the patients, what they want is functioning and pleasing prosthesis. So why do we remove the implants? Well, one of the reasons is periimplantitis. Now, periimplantitis is a different disease in terms of definition. You know that there are different definitions that are used worldwide, and this causes a difference, a very important difference when it comes to prevalence of the disease in the different studies. It goes from 5% to 30% of the implants in the long term. But anyhow, periimplantitis is not the disease that has to terminate the life of an implant in all cases. There are cases like in this situation where with a reconstruction technique, with a GBR technique, you can solve the situation, okay? But it is clear since many years, and this is the ITI consensus paper in 2013, that although we have good short-term outcomes in many studies do report lack of the disease resolution and progression of the disease. So implant loss is something that can happen because of periimplantitis. And in some situation, we need to surrender and just remove the implant, okay? And I will show you a case where this has happened. And it is a combination of an implant disaster for periimplantitis and periodontitis. Of course, this is a patient that has been not treated because of the main disease, but just restored, implants placed and prosthesis provided to the patient without any thorough treatment plan. Now, of course, here we have to solve the biological issue and then think about restoring the patient. And if you see here, we have periimplantitis in most of the implants that are in place, bone loss circumferentially around most of the implants, but also a periodontal issue in remaining teeth. This is considered to be a hopeless situation, at least in our hands. And so we have to think about removing everything and then restoring the patient again. And in this respect, we have learned that the extraction of the teeth and the removal of the implant should be planned in terms of timing very carefully. Because if you are able to maintain, at least for a short period of time, some of the abutments to support a fixed provisional restoration, your life and the life for the patient will be much, much easier. And this is what we did in this particular case. You see in red highlighted 4 of the hopeless implants and teeth that were treated so as to support a provisional restoration during the healing of the newly placed implants. Also in the lower jaw, something is done, of course, and the completion of the extraction is performed. The patient still has a fixed provisional restoration, and then the final reconstruction can be completed by removing the last abutments that were present at the patient presentation. And of course, also the lower jaw is treated accordingly. So even when you have a disaster situation, when you want when you decide that you're going to eliminate all the implant or natural abutments, you still need to carefully plan the extraction or removal phase so that you can go from a situation like this to a situation like this. In here you see the 4-year follow-up of this case, where it looks like the patient is now performing a decent oral health, and his dentition is, I would not say back in place, but he's acceptably restored. The other reason why you would remove an implant is malpositioned implants. Okay, here of course we have a situation where there is a combination of malpositioning and biological issues at the level of the natural abutment and of the implant abutment. And of course, this is something that we cannot use for a new restoration. None of this abutment can be used. You see, many implants were placed, probably too many, and the restoration is a disaster, is failing. Also, the lower jaw has an issue. While in the lower jaw, it is probably impossible to use these abutments to support our provisional restoration, we will try to keep some of these abutments of the upper jaw to support our fixed provisional restoration and finally restore the patient. So we are performing some extractions. We are trying to clean up the patient mouth a little bit, but still we are keeping some of the abutments that lately we will extract according to the staged approach that we published several years ago together with Professor Ercoli as well. And then you have an easy surgical access if you have to perform some minor augmentation, as in this case. It is pretty easy to treat the patient because during the healing, the patient will use a fixed provisional restoration. So there is little influence of the provisional restoration on the soft tissue healing. So you have a situation where you end up with newly placed implants and the old abutments, and now you're ready to complete removal of the natural abutments and failing implants and perform your final restoration. Only this implant here on the position of the first premolar on the left upper quadrant is one that was present in the patient mouth at presentation, without the need to use a removable provisional restoration. The baseline situation and the final restoration in place. And of course, this brings back the patient to acceptable function and aesthetics with probably an easier approach for the patient and for the dentist. So you will realize that also in really disaster cases, as in this that we are seeing, we still try to keep some of the failing abutments to support our provisional restoration as far as possible. You see here we have in the left upper quadrant a disaster, and we also have peri-implantitis on both of the lower jaw implants. There is suppuration almost everywhere, and when we extract the mobile portions of the restoration, we end up with this situation. We try to keep some of the abutments in the first quadrant. This patient would need, as you will see, an extensive bone reconstruction. Just to let you understand what kind of defect we have, you see here this central incisor. When it is removed, you see the amount of plaque and an inflammatory tissue that is attached to it. We let everything heal for 4 months. We still try to keep this horrible fixed provisional restoration that helps the patient to maintain a decent function. And you see the amount of bone deficiency that we have in the region of the central incisor in the right quadrant, or in the posterior, intermediate and posterior sections of the upper left quadrant. Intraoperative view with the very, very extensive resorption of the ridge. We perform a sinus floor elevation, and we have to go to the hip, take some hip graft the patient, wait for 4 months of healing. This is 10 days post-op, 4 months after. You see the screws that are somehow sticking out of the tissues. They're visible, the lag screws, and then we can place our implants 4 months after the grafting. So it's 8 months after the removal of the failing implants, and we are then ready to proceed with the final restoration. We still need to extract these two abutments and the old implant that was placed in between the cuspid and the second premolar in the right quadrant, and to remove the unique old implant in the lower jaw that will be that has been used to support the nova denture, and that will then be replaced. So I think that I would be happy to reply to any of your questions, and I thank you for your attention. I hope that to have been in time with my presentation. And just the last comment, since we are in a digital environment, we have the EIA digital days that are coming. You can register for free. In a couple of weeks, we will have in the evening, at least in the evening European time, very interesting discussions and presentation. You can go and have a look at digitaldays.eio.org and see if you were interested in joining this event. Thank you very much.
Yeah, thank you very much, Luca. I should remind all the participants, and I think we have about 153 of them, that if you want to ask a question, please do it on the Q&A. If you look at the little tile on the bottom of your screen, there's a Q&A, and if you write a question, I can pass it along. I don't see any questions right now, so what I'm going to do is ask the other participants on the panel whether they'd like to address a question to Dr. Kodada. So let me ask Lumbus or Carlo or Costas or Nicole, would you like to ask Luca a question? We have a few minutes.
Luca, this is Carlo. A great presentation. I was, you know, your course with your background, you know, in oral maxillofacial surgery, you know, you end up, of course, getting some of these disasters, you know, patients. What would you say for everybody that is a participant? Maybe the number one, perhaps, caution or criteria to try not to get in this situation in the first place? Because you make it look easy, but it's not easy to fix this. It's always a compromise at the end. Yeah,
yeah. Definitely, it's always a compromise. Thank you, Carlo, for the excellent question. Well, you have seen that many of these cases come in with a combination of natural abutment and implant abutment. Now, there is a lot of evidence, a lot of literatures that claims that it is not the case to use a combination of implant and natural abutments to support the same prosthetic framework. So if you feel like that you don't want to extract in a complex restoration, that you don't want to extract a natural tooth, that's reasonable, then you have to think to design your implant supported restoration as a separate entity or several separate entities. This is pretty clear in the literature. You can take the risk to combine a natural tooth and an implant if you have a short span bridge. But when you start combining multiple implants and multiple teeth, we know that the natural roots tend to intrude, so that it's easy to get caries of the prepared abutment, and it does not work. So if you want to keep, if you think you need to keep your teeth there, my advice would be to use a separate prosthetic design, multiple segments. And the second thing, we don't have to forget that these patients should not be treated unless they comply with normal oral hygiene standards. Because if their teeth did not work because of lack of oral hygiene, the implants will probably perform even worse. So there is no way to solve the patient's problem by extracting the teeth and placing the implants if the patients don't understand that they need to maintain the situation. So I think these are the two main goals. And third thing, I would say that full arch restoration are still something that don't work in the hands of everybody, even if this is what the industry is claiming, that everybody can do these kind of restorations. I think that complex cases should be treated into selected environments, I would say like this.
Look, one quick question, just because there is one that came from the audience. We've only got about a minute, so if you could make a minute response to this one. There's somebody who says, thank you, Dr. Cordaro. What's the minimum amount of bone that you need to place an implant in the sinus region, talking about ridge bone? So if you give just a very brief answer, we can go to Professor Petridis. Okay,
for me, the ideal shorter implant in the maxilla is 10 millimeter standard diameter, okay? This means that if you have a 6 millimeter residual bone, you can go for a crestal bone augmentation that is a very, I would say, not easy, but it's something that can be performed by the normal practitioner. I would consider 6 or 8 millimeters implants as, I would say, short implants, and the minimum that you would be allowed to use. You increase the risk of failure, but still it is something that can be used, but not as a single unit restoration, always splinted with other implants. At least these are my guidelines.
Okay, terrific. Thank you very much, Luca and Dr. Cordaro, and thank you for an excellent presentation. We're now going to move to London, to UCLA, the Eastman of London. And we have Professor Petridis, Lumbus Petridis, with us, who's going to give a presentation of treatment of a challenging aesthetic case. I should add, though, and you probably recognize, because I forgot to add it at the beginning, that this whole section is on prosthodontics and implants. And also remind people, as the speaker speaks, if you type your Q&A in the box, the question and answers, then I can pass the question along to the speaker. So go ahead, Lumbus. Thank you very much.
Thank you very much. Can you see my screen?
Not yet. Luca, you might need to stop sharing so Lumbus can then share. Oh yeah, you're coming up. You're on now, Lumbus. That's good.
Thank you, thank you. So thank you. So it's great to be part of this panel. Thank you very much. It's an amazing opportunity. And we have to remember that we wouldn't be here without this man, George Eastman, and his philanthropic work, establishing our institutions. This is the Eastman back in 1931. That's the London Eastman, with their first dental clinic. And we've come a long way since then. Now we celebrated 2 years ago, 70 years as an independent institution, along with the NHS. And in September of last year, we moved to new facilities. So we have brand new hospital facilities, state-of-the-art hospital, little bit further away from where we were, but in the center of the campus of UCL. It's an amazing hospital, and I hope when COVID disruption is over, we can visit each other again and we can show you around. We run 2 programs in prosthodontics, 1-year program which is focused on fixed, and the classic specialist training of 3 or 4 years part-time. And unfortunately, the institute, so our offices were and facilities were also moving back in March 2020, but then we had the lockdown. And this is our new building, which is right next to the hospital. Unfortunately, because of the lockdown, we couldn't carry out the move, but we are unpacking at the moment. So this is our new home, and when you visit us, hopefully we'll be up and running completely. We have amazing new facilities with preclinical and labs, and it will be great to show you around when we're ready. So I thought, I know we have a lot of residents in attendance as well from all over the world. I'll try to go through a case presentation to highlight the thought process. And I know we talk a lot about treatment planning in prosthodontic programs. So let's look at the patient profile and chief complaint first. It's a 23-year-old female. She's a university student. And she comes and says, I cannot stand this anymore. I need to do something about my smile. So she smiles, and this is what we see. And when we first see it, it might seem like simple or complex, depending on your background. But I think, as you will see in a while, it's not as simple as it seems. So this is the picture intraorally as well. And let's look at the history of the presenting problem. So this patient is actually missing the upper left one, or I should say maybe number 9, or I should say maybe, depending on where we are, the upper left one, upper left incisor, depending on where we all come from. So actually that's the lateral incisor, which was once moved mesially with orthodontics a few years back. And that's why you can see also a discolored canine, which was reshaped to look as a lateral incisor. Now, obviously, the upper left lateral also had some endodontic treatment in the past, and hence some discoloration, and the patient did not recall why that happened. Maybe it was because of the orthodontic movement, if it happened too quickly, but the patient could not recall why this happened. So if we, this is obviously some Photoshop, this is how I would imagine this lateral used to be, and then this had to add some composite to make it look better. So the patient has a clear medical history, she doesn't smoke, and there were no abnormalities or asymmetries in the extraoral exam. Obviously, she has a high smile line, and that's something we have to take into consideration. And when we look into her mouth, there are no abnormalities or asymmetries. Overall, she has a healthy periodontal condition with some localized soft tissue recession, as you can see, on the premolars, lower premolars, and some inflammation around that upper left discolored tooth. But overall, she has a healthy bank of keratinized mucosa around her upper teeth. If we look at the radiograph, we do see that overall bone levels are good. And there's a slight loss of the interproximal bone spike between what is now the upper right central and the upper left lateral. That is also to be expected as these teeth were apart and the lateral came into place. So as you can see, a dentist also tried to put some extra composite to probably mask the black triangle. When you see this clinical picture, I had removed that extra bit of composite, so you can see now there's a clear black triangle there. And the endodontic treatment seems good with good quality obturations. And again, patient did not recall why this had happened. And again, that excess composite resin that you can see on the radiograph, that was removed prior to the clinical picture. So let's go to the diagnosis and problem list. And I'm saying this because there's no real disease here. And I know I've been in both sides of the Atlantic, and we have this big debate, what do you put in the diagnosis? It has to be a problem like caries or periapical pathology. So there's no problem, there's no pathology here, but we can say that obviously there's aesthetic issues. There is discoloration of upper left 2, and that includes the soft tissues because also the root is discolorated. and the tissues have this bluish color. And of course, there's a darker upper left tree because of the thinner enamel and the dentin showing through. And we have a clear uneven soft tissue profile and root profile because upper left 2 is a very thin tooth compared to upper right 1. And of course, the high smile line and the aesthetic demands. Now, how do we analyze this case? Obviously, we have to look, if we can, at some objective analysis and some objective problems that we can see. But then we always have to take into consideration the patient. And my colleague in the previous lecture mentioned the issue of the patient. Sometimes we think as dentists, but at the end of the day, we have to service our patient and we have to hear what the patient has to say, even though we may have our own thought process. So patient desires are critical here, but also the cost of the treatment that we're going to propose, length of the treatment, most importantly, the predictability of the treatment. So we're talking about a 23-year-old female, and the way I like to look at it is I think of life expectancy, and that's what I teach my students as well. When I look at predictability and prognosis and aftercare, I looked at life expectancy. So in the Western world, females, if they remain healthy, the life expectancy is in the 80s. So this treatment, whatever I have to do here, will have to be in place and maintained for 60 years. Now I know that probably there's no way, whatever we do, that is going to stay for 60 years, but we have to make sure that the foundation, at least, we maintain it for as long as possible so that this patient can be serviced. And that's the long-term prognosis and maintenance. So, you cannot even start contemplating treatment unless you've thought of all these things and discussed this with the patient, because there's the issue of informed consent. So we have many indices and many checklists to do smile design and check aesthetics of a smile. We don't have as many when we look at individual teeth. And I'm sure many of you will be familiar with this particular one that came out of the Belser group back in 2009. It's the pink and white aesthetic score. So this was the classic publication that came up with this. And just for those of you who might not remember every little detail, the pink aesthetic score looks at the mesial papilla, the distal papilla, whether they're not there, the curvature of the facial mucosa, the level of that curvature, and then root convexity, soft tissue color, and texture. And you get a score from 0 to 2 on these 5 items. So the maximum you can get in the pink aesthetic score is 10. And then there is the white aesthetic score, where you have tooth form, tooth volume and outline, the color, surface texture, and translucency. Again, 5 items that you can get a maximum score of 10 again. So the maximum that you can get out of this pink and white aesthetic score is 20, which is, perfection. So this was meant to be for implants, and that's what this publication is all about. And people have been using this to see whether single implants have been successful compared to natural teeth. But I think it's a very nice tool to use even when we don't have implants, to have an objective analysis of a case. But if we look at this case and we try to assign the pink and white aesthetic scores, and if you just look at these lines with me, mesial papilla, I think, is incomplete, distal papilla is complete, but then many other scores on the pink aesthetic score are incomplete. So that's a pink aesthetic score of 6, not bad, but not very good. The problem, as you can see more, is in the white aesthetic score, where we have a lot of issues, and we have a score of 3. So the total pink and white aesthetic score for this case to begin with is 9. So that's a form of an objective analysis. We have to start somewhere. Then we have to discuss treatment options. So, we can talk about treatment options, and we see the problems, and we can say, what if we move this teeth, or maybe we move this lateral a little bit mesially, so the root is in the middle, and then we can shape the rest of it with restorative dentistry. And obviously, there is a longer time period involved in that, and maybe a higher cost because we have orthodontics involved. But probably, if it's done correctly, it's quite predictable. And because we're keeping everything in natural teeth, it should have good prognosis and easy maintenance. And we can discuss many things about how to move these teeth. One can also argue, why don't we extract this tooth, maybe through slow progressive extrusion, so we bring down also some of the tissues. and then place a single implant and work with that. And again, quite a lot of time and cost will be involved in this treatment. Predictability, yes, in the hands of very good clinicians, this can work. We've done this thing many times. So we do explain to the patients that that it is a treatment we can do. However, when I see a high smile line, when I see that we're starting with an equigingival level, and actually, if you see the upper left 2 level is 1 millimeter higher, more cervically compared to upper right 1, I can never guarantee predictability. Even if I know I'm going to do a very good job, I can never tell the patient, don't worry, everything will be okay. I think that's a big mistake to start with. It's good to keep their expectations low. And of course, the other thing about an implant is that, what about prognosis and maintenance? So if this implant is going to function for another 6 decades, are we going to have problems? And it may not be peri-implantitis, as my colleague just talked to us about. It could be the fact that it's a 23-year-old female, and we know from the literature that there is continuous growth, and this implant might be malpositioned in 10 years' time, and we have to do other forms of intervention. So I usually try to want to avoid dental implants in young people. And then, of course, we have the restorative work. You know, what if we just try to work with things as they are now, which obviously it's quicker. The cost may be more manageable, but again, predictability-wise, out of the start, I cannot tell the patient if this will work. I can say we can try, but you know, this might not work. We may have to find other solutions, so I may not be able to give you the perfect result. But certainly in terms of prognosis and maintenance, again, it's a plus. Also, again, before we even start, at least in my mind, I want to know what materials I may be working with. So could it be a direct composite, or could it be indirect materials like metal ceramics, glass-based all ceramics, or polycrystalline based all ceramics like zirconia? And also, if I'm going to do an indirect restoration of some sort, will I do a full coverage or partial coverage, and on which teeth? Now, I think we all know that there are quite a few colleagues that would probably involve both upper right 1 and upper left 2 in whatever restoration happens, in order to give the dental technician the opportunity to have a perfect match between those 2 teeth. I'm not a big fan of that approach. I've seen it many times, and it's beautiful actually, but I'm always thoughtful of the damage I do with more restorations on teeth. So all of these things have to be thought of before we actually start the treatment, at least in my mind, because many of these will change my clinical protocols and my prognosis. So after discussing with the patient, after going through the pros and cons, we both decide to try to go with the restorative work and see where that takes us. And of course, the major first hurdle is the discoloration. And you can see we're starting with an almost C4 in the classic Vita Shade Guide. We know we have a problem of tooth form. We know that we have a discolored also canine, which is slightly also shorter. And obviously we have the reverse shape of the interproximal tissues. Of course, this is prosthodontics. The first line of defense is that we're going to do a diagnostic wax-up. So that can be done by all of us, I think, in the dental office. We don't need a lot of infrastructure. But we can see that in terms of ratio, that doesn't look bad. I mean, the problem, of course, is the soft tissues and the color. But it does give us an initial idea where we can go. So for me, and I think for all of us, having done restorative work for years, the substructure color plays a critical role in material selection. And for me, material selection affects my clinical procedures. So in other words, as a clinician, I have my own biases, and I can show you some literature later. I prefer to use etchable glass-based restorations. I think they're much more predictable and much more documented compared to polycrystalline zirconia type of restorations. So if I have a discolored background that I have to hide, which means I have to use either metal ceramics or zirconia type of ceramics, that will change my clinical protocols, and in my mind, it may change the prognosis and maintenance. So substructure for me plays a critical role. Ideally, the restorative material should not try to mask discolorations. And we have to remember that also the underlying root color affects soft tissue color, and that we cannot change it just with a crown. So we'll go through 3 weeks of internal and external tooth whitening with 16% carbamide peroxide, and we have a very, very nice result. As you can see, the tooth is actually slightly wider than the composite buildup that you can appreciate. And of course, as we all come from different places, in the UK, the regulations prohibit us from using any tooth whitening agent which is above the 16% carbamide peroxide. It's illegal basically for dentists to do that. And that came into effect a few years ago. I know in other parts of the world you can use stronger agents. So this doesn't necessarily apply. You can use different agents as long as you can do some internal and external tooth whitening. So that takes care of the discoloration in a very nice way. And we're gonna take care of the upper left 3 later. And then next phase is soft tissue recontouring. So I treat this soft tissue as if it was a papilla, a mesial papilla of a single implant. Okay, there's plenty of soft tissue there. I can slightly excise some of it, but then I can recontour through my provisional the rest of it the same way I would recontour the papilla of a single tooth implant. So this is a bis acryl restoration. That's day 1, and that's 2 months after soft tissue healing. And then you may be asking, you know, what is the underlying tooth preparation? So I chose to go for a, let's say, extended veneer preparation, so almost a 3/4 crown on the facial, so partial coverage. That is for 2 reasons. One, because this is a lateral incisor, and you know, if we try to prepare more, it's quite catastrophic, and we don't need to, in all honesty, to prepare more for aesthetics. And also because in my mind, I'm thinking of maintenance. So I'm thinking, what if this discoloration has a relapse after a few years? I want to be able to have access to the palatal access canal to maybe do some more internal tooth whitening in the future. But what you can appreciate is the healing of the mesial papilla, which may remind you of a papilla next to a single tooth implant, and how, you know, the provisional can shape that. And now, of course, it's more of a technical work where the dental technician has to put their mastery. And as I always say, they are my right or left hand, depending on if you're right or left-handed. But in prosthodontics, half of your work is dental technology, and we have to appreciate the work of people that are working with us as dental technologists. So, you know, we take the impressions. In the impression, please note that we do impress the papilla as well. The technician has to have that papilla impressed. And then the technician will make a glass ceramic extended veneer. That for me is the best material to work with. And I can take you through some literature that I've had the chance to co-author. One is research from 2017, one is older from 2012. But I really think that if we're talking about anterior ceramic veneers, we really have proper documentation for feldspathic or maybe glass ceramics and nothing else in the literature. So I prefer to go with materials that I feel comfortable. I'm not testing on my patients, and they have long-term, or at least some medium to long-term predictability and evidence base in the literature. So we go from this initial position to this final with a new restoration in place and some whitening of the canine as well. And I have to give credit, of course, to my technician, Mr. Agelu from Oral Design Group, who is in my hometown of Thessaloniki. And now we can go back to the objective assessment. And I think now you can appreciate there's no perfection. There's always something that you can critique. So for me, the level of the soft tissue was still not perfect. It was still a bit higher up by maybe 1 millimeter. So the pink aesthetic score for me here is 9. But I think we've done a good job in the white aesthetic score. I can critique a little bit the texture of the restoration, but I think we've gone from a 9 to a score of 18, which objectively is a big improvement. If we reflect on this case, I try to show the importance of treatment planning in a case that looks relatively simple, but you know how many things you have to go through before you even touch the patient. And the informed decision that has to take place as a very critical aspect. I think I demonstrated an objective aesthetic improvement, which is maybe good for all of us to do and critique our work. But the most important aspect is that the patient was very happy. You know, we have to meet patient expectations, but patients will never blow up pictures in a PowerPoint the way we do and critique each other's work. Sometimes we have to remember that patients will be happy even if we're not completely happy. And this case was managed in a conservative manner with a manageable investment in time and cost. And I think the prognosis of the treatment outcome is good. And we have made provision for any relapse by using partial coverage. I think hopefully I demonstrated that with proper planning, the goals of treatment were achieved. So I hope I was within my time. I'd like to thank you for listening, and I'm happy to take any questions.
Thank you very much, Professor Petridis Lambis, I should call you, and
Yes.
It was an excellent and very comprehensive presentation, and it really illustrates how important it is that you be very detail-oriented and use the available evidence and a whole lot of other stuff in the art of actually doing this kind of work. But terrific presentation. There was one question, I think you partially answered it already, but maybe you can expand on it if you could do it very quickly. It was somebody who was suggesting that, well, he actually said, would you consider to center the lateral incisor with orthodontic treatment to facilitate or enhance the prostho restoration? I know that you did mention that as one of the perspectives, and maybe just add maybe to the question so you can understand why you chose something else.
Yeah, so if you remember that table I showed with the different options for treatments and then the different things we could think about those options, orthodontics and then restorative dentistry was one of those options. Either maybe mesializing that lateral a little bit, or even distalizing the whole thing and make space for a central incisor. And we went through that with the patient, but again, if you look at time, if you look at the cost, that didn't tick the boxes for the patient. They were really fed up with this whole situation. So it was in our armamentarium should the plan we followed would fail, because we did say, if you remember, there was an X and a check mark. We were not sure to start with if the conventional approach would actually work. But yes, it's an option, of course.
Yeah, and absolutely. And you did mention it, so I appreciate it. Okay, well, I think we're out of time, but we appreciate your presentation. We'll go on to the next one. Thank you very much.
Thank you.
Thank you, Lambis. Our next presenter is from Stockholm, Sweden, and at the Eastman there. Her name is Dr. Nicole Winitsky, and she's got a really excellent presentation on single anterior implants and their long-term follow-up. And it's a long-term follow-up study, as I understand it, so we look forward to hearing their presentation. Why don't you go ahead, Nicole, and share your slides. Thank you so much. I would like to start off with just expressing how much I appreciate this initiative with the Eastman International Alliance Grand Rounds. I think it gives us an excellent opportunity to share our experience and knowledge between the different institutions. And of course, I'm really glad to be able to be one of the presenters today. My topic for today, as Dr. Meyerowitz said, is a long-term follow-up of maxillary anterior implants. And this is a research project that I'm working on. My name is Nicole Winitsky. I am a prosthodontist at the Eastman Dental Institute in Stockholm and also a PhD student at the Karolinska Institute. This project is a collaboration between both Folktandvården Dental Eastman Institute and the Karolinska Institute and also the Sahlgrenska Academy at the Gothenburg Institute. So this project is divided into two parts. Study 1, that was published in 2018, is called A Retrospective Long-Term Follow-Up of Brånemark Single Implants in the Anterior Maxilla in Young Adults. And in this first part, we're focusing on the clinical and the radiographic parameters. The second part is built on the same patient material, but in this part, we're studying the infraposition and the influencing factors and also performing an aesthetic evaluation. And this part is still in manuscript. So the aims of these studies are to investigate implant success, survival, and complications,
of the hard and the soft tissue surrounding the implant. It's also to analyze the degree of implant position in relation to adjacent teeth, and to investigate the correlation between possible factors influencing the degree of implant position, and also to study the patient's and the operator's aesthetical evaluation of these single implants after long-term follow-up. The first single implant that was placed, the Brånemark single implant, was placed in 1982. So just to give you a little bit of a background around this project, what happened after that was that it actually took 7 years before a method was fully developed to be able to treat patients with single implants. At this point, it was mainly adults that was treated, and there was actually some problems with the treatments at the time. We had some problems with the screw inside the abutment unloosening, and the crown would start to rotate. So not until 1992, when the 01 single tooth abutment came on the market, we actually had a good solution that would help us get a construction that would both stay in place and would also give us a better aesthetic solution. So in 1994, Birgit Tillander and co-workers in Gothenburg, they had a study made on implants in adolescents. And in 1996 and 97, at the Eastman Dental Institute in Stockholm, Kerstin Olga, that was the boss of the Department of Juvenile Prosthodontics, she started a study of the first 42 young implant patients treated with this 01 concept. And I am really grateful to Kerstin, because that she started this project in 96, 97, gave me the opportunity of taking these patients back into the office and examining them again and see how it worked after a long time follow-up. So what we do know about implants is that they end up in implant position due to continued changes of the face. The main changes occur in the lower part of the anterior face. We also know that physiological hard tissue remodeling and soft tissue changes are expected in the face all throughout life. So moving on to study number 1, that focuses on the clinical and radiographic parameters. The material consists of 42 patients. They're all missing teeth in the anterior maxilla, and it consists of 24 men and 18 women. In total, they have 53 single implants, which means 1 to 3 implants per patient. And the mean age of the patients in this group is 20.7 years. And the main reasons for tooth loss is trauma and aplasia. All patients received Brånemark implants with a machine surface. On top of this, they received 01 abutments with cemented alumina crowns. And the delivery of the prosthetic reconstructions was in 1996 and 1997. So the clinical examination that was performed when the patient came into the clinic after 14 to 20 years was that we looked for complications, both biological and technical. We also looked at the patient's occlusion on the implant, and we also looked at biological parameters such as plaque, leading on probing, and probing depth. We also took up a medical history where smoking was one of the questions asked. We looked at survival and success. We took photos of the patients. We took impressions for study models. Intraoral x-rays were taken, and the patient and the examiner both performed an aesthetic assessment. So we also did radiological measurings of the bone changes, and these were made by measuring from the cervical implant color down to the marginal bone level. We used the mesial and distal measurements and used the mean value of those when we did our analysis. We also did some clinical measurings of the probing depth, and this was made with a 4-point scale. So at the 14 to 20 year follow-up, 40 patients out of the original group of 42 was examined. They in total had 51 implants in the anterior maxilla. The mean age at delivery was 20.9 years, and the mean follow-up time 16.7 years. So moving into the results, we found that looking at the bone levels, we found a mean bone loss of 0.1 millimeters. If we look a little bit closer on this figure, where every rod represents one single implant, we can see how some of the implants have actually lost bone, while some of the implants have actually gained bone. If we draw a line on 1 millimeter, we can see that we have 9 implants that has a bone loss of more than 1 millimeter. If we put a line on 2 millimeters, we can see how there's 1 implant in the group that has a bone loss of more than 2 millimeters. Looking at the probing depth, we found a mean probing depth of 4 millimeters. And also here, if we look at this figure where every rod represents a single implant, and we draw a line of 6 millimeter probing depth, we can see that we have 9 implants with a deeper probing depth than 6 millimeters. So of course we start to ask ourselves, are these the same implants with a deep probing depth that also has the most severe bone loss? So we put that into a chart where the blue rods are now the marginal bone level changes, the green ones are the probing depth, and we also added bleeding on probing as the red dots to see if we could find any pattern of a deeper probing depth being more common in combination with bleeding on probing. This chart showed us that we couldn't really find any kind of similarities between different parts. We also did an analysis, statistical analysis with the Pearson correlation test, where we wanted to see if we could find any correlation between the probing depth and the bone level changes. We didn't find any significant correlation between the two. We also looked at bone level changes, if we could see any difference, whether the patient was smoking or not, or whether the implant was in occlusion or not. We didn't find any significant difference between the two here either. So moving on to the complications, we were looking at both biological and technical complications. The biological complications consisted of fistulas with or without pus, or pus without any fistulas, or soft tissue retractions with visible titanium. This existed in 19 patients. If we move on to the technical complications, we found chipping of the ceramic, we found fracture of the ceramic, abutment screw loosening, re-cementation of the crown, and also crowns that had been changed. And this occurred in 21 implants. So looking at the success of the implants, if we correlate this to the Albrechtson and Isidore regulations about what success is, they've set up the rules that if we have less than 1.5 millimeter bone loss during the first year and less than 0.2 millimeters bone loss per year, and no mobility, no pain, and no paresthesias, we have a successful treatment. So if we look in this group, we found an 0.2 millimeter bone loss during the first year and a mean bone loss per year of 0.01 millimeters. We found no mobility, no pain, or no paresthesia in any of the patients. Looking at the survival, the implant survival consisted of 2 implants being lost in 2 patients. 1 was lost after 3.5 years and 1 after 11 years. Looking at the survival of the implant crowns, 10 crowns were lost in 6 patients, 6 of them in 4 patients due to trauma, and 4 of the crowns in 2 patients due to aesthetic reasons and infraposition. So to conclude this first study, the bone changes and probing depth after 14 to 20 years showed an 0.1 millimeter mean bone loss and a 4 millimeter mean probing depth. And if we look at the survival and complications after 14 to 20 years, we have a 96.1% implant survival, and we had an 80.4% crown survival. And the biological and technical complications occurred in 21 patients in total. So we move on to the second study, where the topic is infraposition, influencing factors, and aesthetic evaluation. So the measuring of the infraposition can be made either incisally on the teeth, or cervically, or it can also be visible by looking at the buccal positioning of the implant tooth. This occurs due to the maxilla and the teeth adjacent to the implant moving in an inferior and posterior direction. The implant that is ankylosed attached to the bone will not follow the movement of the implant or the maxilla, and instead it will end up in a position where it becomes a bit shorter and a bit more buccally tilted. So what I was lucky to have was the study models from Kerstin Olga from 96 and 97 that I can then compare with the study models taken 14 to 20 years later. So what we did was that we scanned the models and we superimposed them onto each other in a digital software called GeoMagic. In this system, we could then both visualize and measure the movements of the neighboring teeth in relation to the implants. And in all cases, we used the mesial tooth to relate to the implant. The movement was measured in 3 different directions. We have the X direction, that is the mesiodistal movement. We have the Y direction, that is the incisal movement of the neighboring teeth. And we have the Z, that is the buccal-palatal movement of the adjacent tooth. What we also did was that we determined the facial type of the patient. And this is made by using the anterior facial height, which can be divided into 2 parts: the lower anterior facial height and the upper anterior facial height. So if we use the measurements of the lower anterior facial height and divide it with the total measurements of the anterior facial height, we get a quota. If this quota is higher than 58%, we have a patient with a long facial shape. If this quota is lower than 56%, we have a patient with a short facial shape. Moving on to the aesthetical evaluation that was done with the visual analog scale, both the patient and the operator asked the question, how satisfied are you with the aesthetics of your or the patient's implant crown? This was then plotted on a line from 0 to 100, where 0 was not satisfied at all and 100 was fully satisfied. So the results of this part of the study was that 32 patients was examined after 40 to 20 years. We used only 1 implant per patient if the patient had more than 1 single implant, and then the implant in the first quadrants was chosen. The mean age at delivery of this examined group was 21 years, and the mean follow-up time was 16.5 years. So what we found was that looking at the tooth movement in incisal direction, all implants showed a movement of more than 0.1 millimeter, so some kind of movement. The mean and median value was 0.8 millimeters. If we look at the movement in the buccolingual direction, we found that 70% of the implants showed buccal tilting. And the mean value of the movement in this direction was 0.3 millimeters. Looking at the mesiodistal movement, all adjacent teeth showed some kind of movement in these directions, but these movements were very, very small. We can see here on the mean and median value that we have a value of 0.01 millimeters, which is very, very small and couldn't be considered to be clinically relevant. But if we look at this picture, we have the baseline picture with an implant in the upper right 1 position, and we have the follow-up picture. And we here have a movement of 0.01 millimeters in a distal direction, 0.5 millimeters in a palatal direction, and 0.4 millimeters in incisal direction of adjacent tooth. And we can see how here that although these movements are very, very small, all together, they actually give the implant a new position. And when this little diastema is opening up in between the teeth, this is something that actually the patients start to react on. So we were trying to make this a little bit more clinically relevant by choosing the measurement of 1 millimeter movement as a level where the patient can actually start to see that something has happened. And we found that 30% of the patients had a movement of more than 1 millimeter. We also found that teeth adjacent to central incisor implants had a movement of 0.5 millimeters, while teeth adjacent to lateral incisor and canine implants had a movement of 1 millimeter. So what did the aesthetical evaluation according to Weiss show? Well, we can look at the column where we have the patient evaluation, and we can see that the main part of the patient has graded their implant aesthetics as good. So we can say that despite the infraposition, the patients are actually satisfied with the aesthetics of their implants. If we compare the highest value here that the patient had with the one that the dentist had, we can also see, as shown in several other studies, that the patients are more satisfied with the dentist with the aesthetics. So let's conclude this second study and show that 100% of the patient's implant ended up in infraposition. Implants in lateral and canine positions showed a greater infraposition than central incisors. And we could also see that the greater vertical changes, the more buccal tilting occurred. We can also say that although 100% of the implants end up in infraposition, 87% were satisfied or very satisfied with the aesthetics of their implants. Only one patient was not satisfied at all with the aesthetics of her implant crowns, and the patients were more satisfied than the dentist. And trying to see if we could find any predictors to future infraposition, we can conclude that age, sex, and long face was not found to be reliable to predict future infraposition. We did, however, find that less extensive positional changes was shown if the lower anterior facial height was smaller than 70 millimeters, if the implant was in occlusion, and if trauma was the etiological factor for the patient losing their implant in the first place. So with that, I would like to thank you so much for the opportunity of speaking here and your attention, and I'm open to any kind of questions. Thank you.
Nicole, thank you very much for an excellent presentation. Really amazing to follow it for that long, and you have so much data. There are 3 questions, but unfortunately we're not going to have enough time to handle all of them. So let me tell the people that we will actually forward the questions to Dr. Winitsky, and she will actually be able to respond to you. I'll give her the shot to answer this in maybe 1 sentence, Nicole, because just one of the questions. Do you think the implant tooth movement occurs within the first years or throughout the follow-up time? What's your guess? Do you have any idea? You don't
I don't want to answer that because I don't know, but we do have models in between, and I intend to look after. I have a 5-year period that I can follow, and then I can follow from the 5-year up to the end follow-up. So that's something that I would like to look into. But if I would guess, I would say that the main part occurs the younger the patient is, but I can't promise that.
Okay, good answer. And I think the other 2 questions, actually, one relates to the age. And so we will, Dongjia Ye asked a question, but I will forward, and Philip Guri asked you a question. I will forward those, or Keith will forward those to you. And if you could just respond to them by email, that would be great. Thank you very much. Thank you, Nicole.
Of course, thank you.
Okay, so we move ahead then to the last presentation. And it's from Eastman in Rochester. We have 2 excellent presenters, Professor Carlo Ercoli and Konstantinos Choklidakis. are going to do this presentation. They're going to do this together. Carlo is going to start out, and Kostas is going to continue. So thank you, and why don't you go ahead, Carlo? Thank you very much.
Well, wonderful. Cyril, thanks a lot, of course, for organizing this. Without you, it would not have been possible. It's a fantastic opportunity to get together. So Kostas and I have titled our presentation, Prosthodontics at the Crossroad of Biology and Technology, because we truly believe that it is at the intersection of these two large body of knowledge that our specialty really has flourished again with a greater renewed interest, of course, from applicants and the public. I will present a case which really has a interdisciplinary type of approach. And as you can see here, there is a middle-aged female in which we have a number of anesthetic concerns related to midline, canto-occlusal plane, discolor and opaque restoration, which we're covering, tetracycline stained teeth. You can see again all of this from a frontal view, but it is also apparent from a lateral view that there is a significant concern from a periodontal standpoint, where we have some considerable recessions that are fairly anesthetic, likely caused by her desire in a younger age to brush away, for lack of a better term, what she perceived to be a staining, not realizing that was an intrinsic tetracycline stain. So of course, when we have this situation, it's generally a interdisciplinary case that in this specific case could involve also orthodontics, but in this case, the patient was not willing to undergo that part of the treatment. So the thing that we have, of course, are clear. You can see that there are some older restoration, fairly opaque, of course, to mask that tetracycline stain. But most important, we have a soft tissue component which must be addressed in the context of the overall treatment. Again, those recessions somehow must be treated. So it is important, of course, at this stage, the communication between, in this case, I did the treatment myself, but in case there are different individuals, that we duly undertake a process of communication before the treatment is actually carried out. Now, at the beginning of these cases, of course, you have a number of iterations in terms of mock-ups, in terms of perhaps temporary restoration, where you're trying to correct some of these anesthetic characteristics, like in this case, the occlusal plane. And we see that we still have to do a fair amount of work. But when we look at the interface, again, within the soft tissue, where a lot of the aesthetic value will be created, as Professor Petidris showed, we need to realize that in these cases, it is of paramount importance to make sure that the restorations that we will try to design has an apical extension that is what we expect, what we believe will be the clinical crown that we want to develop, so that eventually the periodontal surgery that will be carried out can actually use that interface as a healing interface. It is not really different from what we do in periodontics when we rebuild the CEJ component of the tooth ahead of periodontoplastic surgery. Again, the gingiva will conform to the shape of the tooth upon healing. So in this specific case, we'll follow the teaching of one of my compatriots in Italy, Giovanni Zucchelli, who is probably the worldwide authority in this area. And what we are basically trying to do in this case is to have some kind of an envelope flap. It's a complex flap with a split full and a split type of approach that will have at the center of the flap around the canine, and it will tend to rotate in two directions to cover, of course, those recessions. Once the papillas are de-epithelialized in order to provide a valid vascular bed for the flap to actually heal, then we need to address the thickness of the tissue because it is often seen. In this case, you see that there are some connective tissue grafts that have been placed on 3 locations, but we know that recessions are more common in individuals with the so-called thin phenotype, where they have a small amount of gingiva, a thin gingiva, and often coupled with the bone thin morphotype, where actually there is a lack of buccal bone or perhaps a thin bone. So again, we got to change a little bit that phenotype in the process. And here you can see the final suture with some sling suture of the right side. And then we use a similar approach from the left side. Now here, however, there are a few things that I need to point out. If you notice, the interproximal space between tooth number 22 and 23, from an international numbering standpoint, is certainly very tight. And the papilla that we have is located more apically, which will have an influence, of course, on the final result. More important, even if we proceed with the same approach in terms of connective tissue grafting, we do see that the operator, in this case myself, really failed to advance in that area that flapped completely within the interproximal area. We will see the consequence, of course, of that. So once the area is healed, you can clearly see that while the right side, I'll say, will heal relatively nicely, at least based on literature, on the value that we find in the literature, the left side, of course, has some limits. And you can see that there has been a little retraction of that flap, and between number 22 and 23, that area is not really ideal. Again, this could be taken care relatively easy with an additional surgery, but often we find that our patients will say, okay, there's only so many times you can cut me and do this. So we decided to move ahead and trying to then to think, how are we done? And if we look at the literature, we do know that complete row coverage is generally not achieved in 100% of the cases, but generally varies between 75 and 90% of the situation. So again, with that, information, then we will try to move to the more prosthodontic part of the case, where we wanted to be conservative. So we have a number of preparation design we can choose among. And we decided to actually have a vertical type of preparation, like a feather edge or a knife edge preparation, again, to be conservative. We will see another reason why we selected this. The next consideration is gingival displacement. We do this every day, of course, in dentistry. It is normal that we need to displace that soft tissue vertically as well as laterally. And we know from analog impression studies that the typical lateral displacement should be roughly 0.2 millimeter to resist a tearing of the impression material. However, we do not know, and the evidence is much more scarce, what would be the value, for example, for intraoral digital impressions. That's what we end up actually doing. The other part to consider is that gingival management is a biological process. It is clear that the more aggressive we are, the easier it is for the lab technician to identify the margin. But it's also true that that comes with a price in terms of potential recession, especially in thin tissue phenotype. So this is one of the reasons why also we end up selecting, again, a feather edge type of preparation, because then we can decide from an apical coronal standpoint, the actual location of our margin. Having done that, of course, in a digital approach, and thanks to the work of Costas back in 2016, that shows us that these impressions actually do have the same accuracy of analog impression, we can then send the work to our lab, and as Professor Petridis showed, it is truly important to value the dental technologist. So here are Nondas, our Greek dental technologist, design a combination of monolithic zirconia for the molars, as well as a cutback design for the premolar to premolar, still in zirconia, but that will be later veneered with feldspathic porcelain. You can see that it was quite masterful in designing the occlusion so that the feldspathic porcelain will not be potentially challenged upon lateral movement. And you can see here the care that he placed in order, again, to design this restoration. However, it's not unusual to look to see that in this specific cases, when some layering of feldspathic porcelain will have to be done, the lab technician still will want to print perhaps a model, a cast, in such a way that he can then relate this to the real world, because let's face it, we have analog patients, we don't have virtual patients. This is the final restoration, where you can see that in a smile, the midline is still off, of course, and we will see there are some limitations, but we were able to address, to some extent, a large portion of the patient's complaint. If we see now the frontal view, again, you can see that some of the cant of the occlusal plane is being corrected, the color is being corrected. It seems to be a much more pleasing and harmonious type of smile. Here is the lateral views, where you can also see that those anesthetic recession seems to be covered. And also the patient doesn't seem to smile as high. And this is a kind of a byproduct at times of large, let's say, displacement of flaps coronally. Same results on the other side where we had some limitation. And again, from a frontal view, where you can see now that you need to give biology sometimes time to work. And if you let this area heal for a while, you already see that between 22 and 23, that area where the flap was retracted, it does look better now. And perhaps it lends itself to a simple plastic surgery in that area. So again, here is biology is the key, and we need to let that area heal to really see the best differences. This is my last slides, and I'd like to thank you again and thank Cyril for the presentations and the organizations of this series. And I hope that I didn't cut into my brother's time. So thank you very much.
Thank you. So Kostas, you can just go ahead. Thank you. Thank you, Carlo, for an excellent presentation.
Perfect. Carlo, thank you so much for the introduction. And I would also like to thank from my side all the attendees for attending today and all the great presenters with these high quality presentations. Of course, to acknowledge Dr. Cyril Meyerowitz and Keith and the other members that make this event happen. And we can all learn from each other. So due to the limited amount of time that I have, I will jump into my presentation today, which is an ectodermal dysplasia patient. We all know that this is a rare genetic condition, and the prevalence of it is approximately 1 out of 100,000 births. So it does affect at least 2 ectodermal structures such as the skin, the hair, the nails, eccrine glands, and teeth. And also we do have a decrease in salivary flow. The anomalies in the teeth are regarding the number and the size of the teeth. And we do have hypodontia, anodontia, or delayed eruption in many of these cases. And as you see here, we also have conical shape central incisors in most of these cases. So when we treat this patient, we need to have an interdisciplinary approach involving several dental and not only specialists. In many cases, we also need to include medical providers as well due to the underlying conditions. So orthodontists, periodontists, oral surgeon, and prosthodontists are mainly included regarding the dental treatment. Because as you can see here from this patient, we have several concerns. Just give me 1 second here. So here the problems that we mainly see is that we do have anodontia, we have hypoplastic teeth, and this patient have a few of their permanent teeth and many of their primary teeth. My patient here, you see, there was a big diastema, which was a concern for him, and then you can see the conical shaped teeth. So the diagnosis for this case is, first of all, as you see, partial edentulism, hypodontia, conical shaped teeth, loss of vertical dimension, and in many of these cases, we do have underdeveloped maxilla, and that's why the role of the orthodontist is very important in these cases. Here you can see also that we have increased vertical overlap and loss of vertical dimension, which was assessed with aesthetics and phonetics. Also, we had the mandibular tori bilateral in this case. So the first thing that we did in this case, it was a quick wax up. As you can see here, I just waxed up the anterior 6-7 teeth in order to get an idea of the smile of the patient, the size of the teeth, if I would be able to close the diastema, and of course the display of the maxillary teeth here at rest and that smile. So the patient approved this anterior wax up, and then I moved forward to complete the wax up in order to come up with a treatment plan. So the treatment plan consisted of 2 phases. As you can see here, we had to extract primary teeth as well as the upper left second molar. And the surgical phase would include, except for the extractions, GBR, sinus augmentation on the upper left side, crown lengthening minimum in the molar areas, and the premolar that we kept here on the upper right side, and 11 implants. The prosthetic phase included 7 zirconia single restorations on the permanent teeth of the patient. You can see 5 in the maxillary arch and the 2 molars in the mandible, and a 4-unit zirconia tooth-supported fixed dental prosthesis in the anterior. Also, we did have a single implant on the first molar, an implant on the canine on the upper right with a cantilever of the lateral, and then 3 implants on the upper left quadrant, 3 implants on the lower left, and 3 implants on the lower right. So the treatment started, of course, with mounting the cast in the restorative vertical dimension. So I did prepare the teeth on the cast, as you can see here, and then I digitized the cast, and we milled this full arch immediate provisionals. Now you see here the design, the digital design, and as Carlo mentioned before, the digital technology offers us several advantages. We do have the digital file, so if we need, for example, if we have a complication and we need to have, again, another temporary restoration, then you can just push the button and mill it. The modifications that we need to do is pretty simple. You can do that from your computer, from the screen, just moving the mouse, instead of waxing, adding, removing wax, which takes some time. The milled restorations are actually offering strength and aesthetics, and can be used also as a guide for our surgery, as it happened in this case. So after the surgeries here, you can see extraction, GBR, crown lengthening in the maxillary arch, and immediate provisional restorations. These are the same day the surgery was performed, and these provisional restorations that you saw before were reliant, and this is how the patient walked out of our practice. You can see here the 2 weeks follow-up, as well as the 6 months follow-up. The patient was pretty happy. And now once the healing is complete, then we move forward to the implant placement phase. Now this is the beauty of the digital technology. I milled another set of provisionals, both for the maxilla and mandible. I opened the hole, so then we can have a prosthetically driven surgery here. So we place 6 implants in the mandible and 5 in the maxilla. The surgeries were performed of one of our faculty, Dr. Sigarida, and you can see here that she's actually grinding through the guide. So the guide is supported on these 4 teeth, which actually served as the abutments to hold these full arch provisionals throughout the whole treatment. So the placement of the implant was done in both maxilla and mandibular arches. And when the implants were also integrated, then we moved forward to our new provisionals, because we needed to contour our soft tissues and make sure the patient is satisfied in terms of aesthetics, phonetics, and function. So we did perform open tray silicone material impression, and then new provisionals were fabricated. As you can see here, this is exactly the same day that I delivered these restorations, and you can see here a small gap, which I left it for purpose, in order, as I said, to see how much I can get and how much we can mold the soft tissues. So same provisionals 4 weeks. So you can see now this is closed already. We see nice gingival margins, both in the maxillary arch and in the mandibular arch. The patient was satisfied with the aesthetics. We are also satisfied with the occlusion, as well as the function of the patient. And then we move forward to the definitive restorations, which consisted of zirconia layered restorations in the maxillary arch from first premolar to first premolar, and then monolithic restorations in the posterior. So you can see also here the feldspathic porcelain, in order to combine aesthetics and strength. We did also use the angulated variobase abutments here, as you can see, due to the position of the implant, and also we wanted to move the screw away from the buccal area. These are the restorations in the mandibular arch. We have a 4-unit anterior zirconia layered bridge. We had 2 fixed dental prostheses here, splinted from each side, and then the single zirconia monolithic restorations for the two molars. So these are the type of hybrid abutments that we used in this case. So you can see here that we do have a titanium abutment, which now the connection here is with the internal surface of the implant. So we have less wear because there are similar materials. And then on top, we can have the zirconia crown, which can be layered or monolithic. And these two components are actually bonded together. And these are the angulated screw access channels, which allow us to still have a screw retained restoration if there is a small divergence in the path of insertion of our restoration. So these components, we use them a lot, but we still need to be careful and wait for more data, more studies to come out. So when we compare the zirconia ceramic versus metal ceramic restorations, we do have many studies as well as systematic reviews showing that the results, the outcomes are pretty comparable in terms of survival and complications. We do see more chipping in the zirconia layered as compared to the metal ceramic ones, but with a proper occlusion and as well as keeping monolithic posterior crowns, as well as the anterior to layer only the facial sides of the teeth, we do eliminate or decrease the complication rates. So these are the definitive restorations in the patient's mouth. You can see the nice smile and the curvature here, which is following the curvature of the lower lip. We did manage to close the space here, which was a big space, big diastema, without these teeth looking too wide. And these are the intraoral photos. This is, unfortunately, I have only 1 week follow-up. So this is 1 week after the delivery. So I'm still in the process of recontouring here the two lateral incisors because I do have the volume underneath. So I will decrease the modified overlap, ridge lap in this case. And this is the before and after panoramic radiographs. You can see all the restorations that I just described. And you can see here now the transition, the transformation of how the patient was before. Look here, the collapsed bite, look the diastema, and you can see now here the transition with the definitive restorations. And also on the right side, you can see the patient smile before and after with this definitive zirconia layered restorations. So the most rewarding part of this whole treatment for these patients, and not only is the improvement of the quality of life that we see on these patients and the self-confidence that they gain. So this is the reward for us as dental specialists and the service that we provide to these patients and our community. So with this slide, I would like to again thank everyone, and Dr. Meyerowitz, if there are any questions, we will be glad to answer.
Thank you very much, Kostas, and thank you, Carla, for two excellent presentations. I think we're, look, we did pretty well because we've had a lot of presentations and we managed to fit all 4 institutions at once. So I'm sure there are questions, but if people could address them directly to Carlo and Kostas. I don't see any questions in the Q&A. I'm not sure, Lambis, if you have any question for Carlo or Kostas while we are over here. Just a quick question may be good, or a quick comment, and then we can wrap this up.
Yeah, I just wanted to say that I thought all presentations were great, and I think the most important thing is that I thought every single presentation complemented the other ones. So we pretty much touched based on similar issues. You know, Nicole talked about the growth and aesthetics, and Kostas and Carlo. So I think it was great because without really having talked to each other before, we're talking in the same line, which is, you know, great. I think. Thank you all.
Okay, well, I think that's a great way to end it. Also, a great piece of one of the objectives of this whole session is for the Eastmans in the different countries to interact. So now that you guys know each other, Lambis, Kostas, and Nicole, I think we have an opportunity to actually discuss with Carlo and also with Luca other issues. So thank you very much, everybody. And thank you all the participants. We've had a very, very large audience, and I see that we've got everybody practically still staying on. I would remind you just a couple of things, that the next EIA Grand Rounds or Global Rounds are in November, and the topic area will be pain. We will be sending out more information on that. And I would like to thank you again, and I would like you, if you can, to complete the poll evaluation, which Keith has put up on the board. So thank you very much, and ciao. And Nicole, you'll have to help me with a goodbye in Swedish.
Hej då!
Hej då, okay.
Hej då!
Bye-bye, thank you.
Bye, take care, everyone.
Thank you. So if the audience could just complete that. Keith, how do they complete this thing?
You just go down and answer the questions. We have about 100 that have finished already.
Okay, great. Thank you very much.
I'm going to leave it on for a little while for everyone to finish. Okay.
Thank you. Bye-bye.
Bye. Thanks very much.
Thank you, everybody. And just complete the poll. Thank you very much.
Bye.
Excellent presentations. I'm completing the poll myself.